Thanks everyone for joining us today on this Friday. We are blessed to have Dr. Maile Karris, who's going to be talking to us about key populations from a lot of the data from CROI this past year. So here's a quick bio. Dr. Maile Karris is an associate professor of medicine in the Division of Infectious Diseases and Global Public Health and Geriatrics, Gerontology, and Palliative Care at UCSD. Her specific expertise is in the care of older adults with HIV. Such, she is active in both HIV and aging-specific clinical and research organizations such as the American Geriatrics Society's Emerging Leaders in Aging Scientific Interest Group. Through these roles and others, Dr. Karris fosters the performance of clinical, translational, and implementation science research in HIV and advocates for early and consistent community member engagement and guidance. Her overall research approach is bedside to bench. In other words, she pursues research questions that may directly address the day-to-day needs of the people she cares for. Examples of current clinical and research interests include novel approaches to managing chronic pain in older adults living with HIV, development of pragmatic approaches to caring for older adults living with HIV, loneliness, substance use, and HIV aging stigma. All right, Maile, go ahead and take it away.
Thanks, Dan. So I was lucky in that I wasn't assigned a topic. I got to pick a topic. And so I basically kind of gathered a lot of the abstracts and posters that were focused on special populations or key populations, underrepresented populations. All these words we're not supposed to say anymore. But it's important to me, and I know that it's important to my colleagues, and so hopefully we'll have some really interesting discussions. I will say that I tried to specifically select posters that I felt had some actionable data. So, this is not just going to be discussing about mechanisms, although that's amazing and it's super fun. I'm really hoping that takeaways, some of the data today will help you kind of change your practice or maybe further develop your practice in the care of people with HIV. So given Dan's introduction, does anybody know what key population I'm going to be focusing on first? Any thoughts?
Aging
Yeah.
populations, I hope.
Yeah. Yeah, so we're going to be talking first about some posters that are focused on older adults with HIV. So older adults. Thanks to excellent and well-tolerated antiretroviral therapy, people with HIV are expected now to live near normal lifespans. And currently, about 54% of people with HIV in the US are 50 years and older. So this is a big population. In the context of ending the HIV epidemic, the CDC, who put together this poster, modeled an aspirational scenario of us achieving as a country a 22% decrease in annual percentage change in new HIV diagnoses and an adjusted mortality that matches the general population. So currently, we have about a 3% change in new HIV diagnoses annually and have a higher mortality rate than the general population. But CDC was like, let's be aspirational. If we can achieve what we want to do in the context of EHE, what will that look like for us down the line? So they employed a table-based cohort component model to determine estimated numbers and age distributions of people living with HIV over time, all the way out to 2040. And in this scenario, by 2040, the demographics of HIV will continue to shift older, as we see here in the red graph. With 75% of people diagnosed HIV or living with HIV being about 50 years and older. And this trend is observed not just in, like one demographic, but really we're seeing gains and aging and hopefully successful aging across race and ethnicity as well. So some of you might be thinking, yes, we have all the tools, right? We've got great prevention medications. We have great treatment medications. but we're never going to achieve this aspirational rate. But regardless, even if we continue along our current status quo, which is about, again, just that 3% decrease in new diagnoses, our population of people with HIV will continue to age, and that median will continue to move to higher ages. So even if nothing changes, by 2040, 64% of all persons with diagnosed HIV will be 50 years and older. So this is a reality. My takeaway from this is that as HIV providers, we're going to increasingly need to be taking care of diverse older adults. And as such, we should be planning and investing in the integration of geriatric principles into HIV care. And I'm going to try to answer questions in real time. So I'm watching the chat. Dan is also helping me.
Yeah, nothing right now.
Okay. Okay, perfect. So this is coming. I think there's really no getting around it. So how do we do that? Some of you might be wondering, well, I'm already super busy in HIV clinic. How am I going to integrate these geriatric assessments into my clinic time? And yeah, we are. We're already really busy, and there are a lot of things that we're addressing. But I wanted to share this poster because maybe this gives us a tool that would be easily and maybe more rapidly integratable into our clinics. So this poster from our colleagues in Brazil also acknowledges, that the traditional comprehensive geriatric assessment can be complex and time-consuming. We currently do Medicare annual wellness visits at ON. It takes about an hour. If we're lucky, sometimes it's 30 minutes, but it is definitely time-consuming. But it's important to know that there are other options. So in this study, they evaluated 703 persons living with HIV that were age 50 years and older, and they underwent this 10-minute targeted geriatric assessment. It's also known as the 10 TEGA. The median age of this group was 62 years. 63% were men, so their demographics are very similar to our demographics here in the US. And 49% of them were characterized as pre-fail, 6% as frail. This is also consistent with what we've seen in some of our other studies, such as the HALO study. The median time that it took to complete the 10 TEGA, so if those of you are wondering, does it really just take 10 minutes? The median time was 7.5. So like a little bit less than 10 minutes, and nobody took over 10 minutes to complete this assessment. To determine how the 10 TEGA performed against some of these traditional assessments, like the SPPP, or the Short Physical Performance Battery, which is often used to evaluate physical function, and the Montreal Cognitive Assessment, which is kind of a standard in looking at cognitive function. They also tried to correlate how well did the 10 TEGA do against these like well-established but much longer to do assessments. And it actually did pretty good. So the Spearman correlation for several of the assessments, such as like the ALDLs and the PHQ-9, was actually pretty good in the 50s and 70s. I think where maybe there is some deficit is in the social provision scale and maybe a little bit in the MoCA. So those are, okay, but not as well performing as this original, more comprehensive test. That being said, I think the authors found that the 10 TEGA score, whenever someone had a score of greater than 3, it really provided a good balance between sensitivity and specificity for detecting frailty. So this tool was actually quite useful. This is the frailty ROC curve, which really shows that the 10 TEGA of what the cutoff of 3 was really good in doing this. So really the takeaway here is the 10 TEGA is able to identify vulnerabilities that include frailty in older persons with HIV, and may be a way to start integrating geriatric assessments into HIV care. And I put a QR code here in this PowerPoint for any of you who are interested in taking a look. This is the original 10 TEGA paper. And it also has the 10 TEGA assessment in it. If anyone wants to look at that and maybe consider how feasible it would be to start implementing it in your clinic. Now, geriatric assessments focus on things like mind or cognition, mobility or physical function, medications that could be potentially more harmful to older adults than younger adults, and multimorbidity. But really what is most central to the geriatrician and their geriatrics approach to care is that all decisions are centered around what matters most to the patient. So it's geriatrics and HIV, I think, are really similar because we're both very person-centered. And because of that, I think it makes it easier to adapt a lot of these principles into the care that we provide anyway. This poster from Denmark discusses the results of a nationwide study among people living with HIV 50 years and older that aim to explore, their full spectrum of health. A total of 322 men with HIV and 67 women with HIV were compared to age-matched controls of people without HIV. And in the study, people with HIV in general, though, were younger and compared to the controls, but they had higher rates of comorbidity. So men with HIV were more likely to have cardiovascular disease, lung disease, and liver disease, while women with HIV demonstrated more hypertension, liver disease, and osteoporosis compared to HIV negative women. Which, I think we know this, right? We know the mechanisms of some of these comorbidities and why, this is more common in people with HIV. So from a psychosocial standpoint, though, men with HIV were more likely to have symptoms of depression. Again, maybe that's not that surprising, but also were more likely to have a larger social network than men without HIV. And I found that very interesting because it's different than what we observe in our US studies. And Denmark's epidemic was very similar to ours. Theirs also started in the 80s and 90s, and they had a lot of the same issues and concerns that they went through a lot of the same things that our folks who are now older adults also went through. So I was trying to figure out, like, why would there be that difference here in Denmark? And so I Googled a little bit about Danish culture, and I don't know if anybody knows much about that. I did not. But I found that Danes in general tend to embrace egalitarianism, social trust, and community. And men specifically embrace this concept that's known as hygge. And essentially that reflects this concept of like a coziness or a togetherness in everyday life. So they have a little bit of a different culture than our American independence, I need to do it all on my own type of culture, which maybe is explaining that specific difference. But anyway, that I found to be a very interesting finding. I also appreciated that the authors explored sexual health and preferences of these older adults. And surprising to me, but maybe not that surprising given what I also hear on some of our Medicare annual wellness visits, compared to HIV seronegative persons, older men with HIV were less likely to value an ongoing sex life. Older women with HIV were more likely to have no sexual desire, but both men and women with HIV were more likely to experience sexual dysfunction. So there are a lot of sexual health concerns and issues amongst our older adults. And we don't always talk to them about that. So, I think if anything, if you have a little bit of time and when you're older patients that, they've been suppressed forever, overall their comorbidities are controlled, maybe bring it up and see what they say. So anyway, I think I found this to be a really interesting poster, and I'm thinking about how I can potentially integrate this concept of hygge into future interventions. Oh, sorry. That's just a summary. Okay, so the next presentation talks about hearing loss, and there are many modifiable factors that contribute to increased risk of dementia. Examples include if we're not sufficiently treating hypertension or diabetes, ongoing tobacco and other substance use, including alcohol, undertreated depression, lack of physical activity, but also hearing loss. So hearing loss is a contributor to the progression or the development of dementia. The investigators here from Mass General utilize a simulation model to estimate the prevalence of hearing loss and age-associated dementia amongst people with HIV in the US. And they use a Monte Carlo simulation model to predict hearing loss and age-associated dementia over the next 10 years. And inputs included dementia rates by age, as well as the incident rate ratio of people with HIV versus the general population, and rates of hearing loss in people with HIV versus the general population. And they predicted that hearing loss here is indicated in red. Age-associated dementia, which is indicated in the blue in this graph here, and then the combo of hearing loss and age-associated dementia is in the purple. So not unexpectedly, I think, we see steadily increases in all of these conditions over the next 10 years, but it is much more prominent in men or in males and females. However, for both men and women, the numbers of persons with the dual, the hearing loss and the age-associated dementia doubles within that period of time. So I wanted to highlight this poster because I think we sometimes dismiss doing hearing tests. I mean, even in our annual wellness visits, we don't always do a hearing test, even like a brief one in our clinic. But because there is some association with dementia and because it's potentially a modifiable condition, I think it's important for us to start to consider integrating this too, or at least referring to audiometry. And I think this poster really should continue clinics in general to identify approaches to also help out our patients access hearing aids. So hearing aids are not currently covered under Medicare. People usually have to pay for them out of pocket. Costco apparently has the cheapest of all places, but my patients tell me they're not the greatest. So just another reminder that, hearing loss is treatable potentially, and treating hearing loss may slow the progression for dementia. Okay, so as a provider who has integrated cognitive screening into HIV care, I've had many experiences where a patient didn't perform as well on a cognitive screener than they would have expected, and it can cause some distress in that period of time. I've always communicated when that happens, that our cognitive tests are really best used longitudinally because multiple factors can impact a cognitive test score at any point in time, including being nervous about taking your first cognitive test. And this poster by our colleagues in Canada, which also includes Scott, validates that. So they looked at about 268 persons who were longitudinally followed and completed a cognitive assessment every 9 to 12 months or so. The mean age was about 54. A third of the participants here were university educated. The majority were of European descent and had really good CD4 T cells, and I think like a median of 630-ish, but many had had a nadir in the 200s. So over this 10-year period of time, the majority of participants were cognitively stable, and you see that by that nice red line there. And a one-time cognitive test at any period of time did not reliably predict long-term decline. Really, the people who were at greatest risk for cognitive decline tended to be older and demonstrated an overall worse performance on the test. So if they did very poorly, that might be a reason to be a little bit more concerned about their cognition, and maybe that would or should prompt a referral for additional cognitive testing to neurology. But, if they did less well, than they wanted to, but still were kind of like in the middle zone, maybe it's okay to say, hey, there is data saying that like a one-time test really isn't predictive. Let's continue to do these longitudinally. If you notice any other concerns, in like the next 6 to 12 months or so, let me know, and we can kind of consider repeating this sooner than later. But I think it's reassuring to a lot of patients to be like, this is actually common. It's really common to have a one time where you're just like, didn't perform well. And most of the time, it's not gonna actually relate to further progression or decline in cognition. Okay, I'm gonna take a pause. Any comments here? Oh.
Yep. One
Yes.
from Nettie saying, I'm glad you brought up hearing loss. Getting patients good care for hearing losses is extremely difficult, like access to neuropsych eval for memory cognitive deficits. This is another where we need advocacy in the field to press for access to care.
Yes, and we should definitely be having those conversations in this forum, because we are, many people attend here. It's not just UCSD. So thank you, Nettie, so much for bringing that up. We actually, it's not really difficult for us to get people into audiometry for hearing tests. It's a little bit more difficult to get them into ENT after the fact, for fitting and some of these other things. But I can see how the community has a much more difficult time doing that. I'd love to hear if anybody has successfully been able to achieve hearing aids. Is there any hack? Has anyone figured out a hack for that? Because we haven't yet.
I
Anyone?
will clarify, this is Eddie, thanks, Maile. I will clarify that we can get them diagnosed with hearing loss, right? But it's just like, that's not the problem, right? They know they have hearing loss. So the diagnosis, but access to care, having ENT, take a look, and getting hearing aids, it's like, forget it, It's
Yeah.
very frustrating.
Yeah. And it takes money to have a Costco membership, right? So you have to pay to get the decreased hearing aid cost. And even then, some of our patients still can't afford it, So thank you for sharing that, Nettie.
And I think Tari's agreeing with that in terms of the cost is often prohibitive. And someone said, seems like ENT, audiology, and hearing aid providers are not integrated. Lions Club has a charitable program. So that may be something worth looking into.
Yeah, I think Lions Club also helps with glasses. My understanding, though, was that it was like donation based. So people donating glasses and hearing aids versus new hearing aids, but maybe that's not the case. So I agree that that's something that we should look into further. Okay.
I think that's it.
Okay, thanks. So I know that Scott presented this poster last week. This is the ACTG's HALO cohort, about 484 participants longitudinally. But Scott mentioned this work demonstrates really a mixed picture as it relates to inflammatory markers. Some of them seem to be relevant and associated with things like frailty and clinical events and mortality, and others don't. But I wanted to bring this up again because I think the study adds further support and can be used to communicate with our patients that there are several inflammatory markers that are actually associated with increased risk of frailty, clinical events like cancer, cardiovascular disease, diabetes, liver and kidney disease, and mortality. And I like to mention that because sometimes you can communicate that and say, hey, but there are also some health behaviors that you can do and you can be empowered to do that actually fights off inflammation. So taking your meds all the time, starting a statin, cutting down on your substance use and seeking out meaningful social connection. All of those things are interventions that have demonstrated to have decreases in inflammation measured in various different ways. So just to kind of put a little bit of a clinical spin on what Scott shared last week, and hopefully if you're struggling with getting that person on a statin, we'll talk about that in a little bit again. Maybe the idea of, having frailty might push someone over that edge. Another interesting study out of Canada, also with Scott, sought to evaluate if sleep apnea contributes to cognitive issues amongst older adults with HIV. Historical studies in non-HIV folks do not demonstrate a cross-sectional association between sleep apnea and cognition. But symptomatic sleep apnea is associated with the future development of cognitive impairment. So there is something there as far as a rationale for the study. This cohort included 707 persons. They used 2 questionnaires. So they did not actually do sleep studies on these participants, but they had 2 validated sleep apnea questionnaires, STOP, BANG, and the Berlin, to evaluate for risk. Over a third of participants, as you see here, screened positive for sleep apnea. Again, I just wanted to remind you all that this is in Canada. When we've done these assessments in our US cohorts, the rate of positive screening is closer to 70%. Most of those cohorts, though, were predominantly male versus a more moderate mixture of male and female. They then use generalized linear models to evaluate associations between high versus low risk of sleep apnea based on assessments and cognition evaluated by computerized measures of cognition self-report. So they had subjective measures, or at least questionnaires of sleep apnea, and then they did self-reported cognition and actual computerized testing of cognition over time. And they really didn't find any association between the objective cognitive measures and the sleep apnea measures, although there were some associations between the subjective cognitive reports and sleep apnea measures. So people were reporting, like if they had some if they perceived themselves to have some cognitive deficits, that did seem to be associated with sleep issues, but not the official computerized cognitive deficits. Going back to some of the components of these sleep apnea screeners or assessments, loud snoring, nearly daily breathing interruptions, and fatigue tended to be predictive of cognitive difficulties. So those three symptoms specifically may be associated with sleep apnea, may be associated with other factors, but they did impact objective cognitive issues. So, cognitive decline is a fear for all of us, but a lot of our older adults are particularly concerned about it. And treatment of sleep apnea has demonstrated improvements in executive function, memory, attention, and reaction time. So although they did not necessarily see that finding here, I still think that there's value in considering ruling out sleep apnea when you have someone coming to you with concerns about cognition.
So can I ask a question then? The challenge that we have with the whole sleep apnea is obviously adherence then to the sleep apnea, because when I look in my practice, I'm trying to think, maybe 10% or maybe consistent with it, and the other 90 are not. And so that seems to be kind of the challenge. I don't know, maybe that's more of a comment than a question.
I agree with you. I do think there's lots of reasons, right? I mean, I think I have a patient that would greatly benefit from using his sleep apnea machine, and he wants to, but he's currently living in a car, so he can't. And I mean, it really goes back to addressing a lot of these basic needs, and getting people where they feel comfortable sleeping. They can, have a situation where they can have the machine, plug it in reliably, and be able to do that. Actually fall asleep with the machine versus accidentally falling asleep because they are working too hard, or maybe they drank too much alcohol, on the couch. I mean, I think it like anything, you're right? Adherence is important. And maybe if your patient does have sleep apnea and they have a machine and they keep coming back and saying, I'm so tired, like maybe that's when you say, are you using your sleep apnea machine?
Yeah.
Because that will
So,
help.
so we had some other comments from Nettie saying, since the folks who scored lower reported also poor sleep, possible what was showing it was depression confounder in terms of poor sleep cognitive deficits.
Yeah, I agree with you, Nettie. So I do think that there's lots of confounders, right? So substance use can cause poor sleep. Some of our medications can cause poor sleep. Prostate issues can cause poor sleep. So it's complicated. It's not just sleep apnea. And this is a poster, at CROI, and it didn't have all of those components. But yeah. But
Yeah. Someone else said the main challenge I have is getting an appointment with pulmonary. Their schedule is so backlogged, at least at UCSD. Scott also said GLP-1s, maybe. So I don't know if you have any comments on that.
No, I mean, I'm going to talk a little bit about GLP-1s down in a couple more slides, but yeah, I think these are all things that we should be talking to our patients about. There is also some people that benefit from getting surgery. So if you can't get into pulm, maybe refer them to ENT. It seems to be easier to get into our surgical subspecialists and our medicine subspecialists nowadays. So for those of you that are at UCSD, you were sent a survey about wellness. And one of the questions in that wellness survey talks about what specialties are difficult for you to access to. Please put sleep medicine there, because I did. I mean, this is meant, this is not meant to punish them. This is meant to be able to provide them with more support, right? Like this is, by saying that, we're not saying they're doing a terrible job. We're saying they need more support because there's a high need for their services. So please complete that survey. Sorry, this is off topic. But unless we tell them what's going on with us, they will not address it. So for clinical faculty, please do that.
Scott also mentioned about priority of needs, and I think housing is first, abstinence is first. I guess in terms of prioritizing the sleep apnea and treatment, etc. Paloma said, I see that when I try to order a sleep study, the only option available is a home sleep test, which is less accurate than a lab sleep study. I don't know if that is necessarily the case in terms of, I've been able to get people to get it done in the lab, but yeah.
I think we need to encourage our pulmonologists to do another sleep grant, because then they were begging for us to, refer our patients to them. So I'll talk to Bob after this and say, hey, see if he has any other ideas of doing another sleep study grant. I think he might be interested in the cognition aspect of it. So we'll see.
Okay. Last two comments regarding the previous hearing aid. Emily said AARP offers a 20% discount for hearing aids. Did not know that. And Paloma asked, would it be easier if we had an audiometer available in the clinic to help identify abnormal results and expedite ENT referrals?
That's interesting. I don't know how to interpret that, but if someone is willing to get trained, maybe that might be helpful. We'd have to talk to see how we could bill for that, though. That's like a Laura and Irene question. But I love that thinking outside of the box. Thank you. Okay. So one of the things that I appreciate a lot about CFAR is, or the CNEX, the CFAR Network of Integrated Clinical Systems, is that it's constantly growing and integrating new surveys and questionnaires to kind of address the issues that our people living with HIV are experiencing. So a couple of years ago, they actually added some frailty assessments, which enabled this study. And this study is evaluating the relationship between frailty status and mortality. So perhaps not surprising, both the pre-frail and frail states were associated with an increased hazard ratio for death, really for everyone, including what age group you're in and whether or not you're male or female. But I was surprised to see that women and younger persons who were frail had much higher hazard ratios than their counterparts. But then, thinking about it, frailty state in these populations probably is just more surrogate for poor overall health. Because if you're younger than 50 and you're frail, there is something going on. Because frailty states tend to be associated with advancing age, not younger age. So the primary reason I wanted to talk about this poster is that, in the geriatric world, frailty is a state that's usually viewed as irreversible. Again, because it's occurring in the context of advanced age and decreased capacity. However, in HIV, there is evidence for reversal, and longitudinal data demonstrates that people with HIV sometimes go in and out of the different frailty states. So I think the difference is that most people living with HIV are still chronologically young, at least now they are. And many of the factors that could be contributing to a frailty state may be reversible, like substance use, sedentary lifestyle, and untreated HIV. So I think, like addressing and counseling about functional status and these modifiable factors may overall help our patients as they age and help them age well. And aside from lifespan and health span, there are other societal reasons to address frailty and subsequent falls. The investigators of this poster employed a status quo microsimulation to project the potential of life years lost and attributable costs associated to amongst persons with HIV who are virologically suppressed based on their functional status. So the simulation included people who were 40 and older, although the cohort mean age was 56, so it matched what our current state is. And they used prevalence data from the HALO study to input pre-frailty and frailty prevalence. In the status quo projected life expectancy, which is basically they didn't incorporate any of those factors. It's just, okay, what does it look like if there was no frailty, no pre-frailty, and no falls? we did see a life expectancy that ranges on average between 20 to 22, and some costs that were attributed to that. However, inputting real world current rates of frailty and falls, as well as pre-frailty, demonstrates pretty significant increases in life years lost at both the per person and population level. That's the graph on the very bottom on the right-hand side of the screen. Frailty itself is 2.44 life years lost per person. But what was really remarkable to me is how much that translated into cost, particularly at the population level. So frailty, the frailty state in older adults with HIV had an attributed cost of $8.2 billion over that period of time. Falls is just about 3.4 billion. So really the potential individual and larger society costs are astronomical for these conditions. And if our country was really interested in addressing waste, this work makes a great case for investing in health insurance paying for interventions that prevent frailty and falls. But I'm not a politician, so I have not yet put that bill in.
There was one comment about, I think, the younger and older frail people. Scott said wider confidence intervals for the frail among the young. So probably not common, but when present, it's bad. So I think I agree with that as well.
Yeah, and I'm sure all of us can think in our heads, can already picture a couple of our folks that, would fit in that category that we're really worried about. But yeah, I agree, Scott.
Yep.
So I think most of us would agree that the data is incredibly compelling for statin use in people with HIV, at least who are 40 years and older. Statins, though, have a pleiotropic effect in that they lower lipids, decrease cardiovascular disease risks. They can decrease inflammatory biomarkers. At least some studies have showed that, not all. And they could also be impactful on cellular hallmarks of aging. So this is an international study that aimed to evaluate if frailty trajectories differed in people with HIV who used statins versus those who did not. And it was actually a pretty large study, as you see here by the ends. Not surprisingly, people who were on statins looked different than people who were not on statins. Persons on statins were more likely to be male, older, have a greater waist circumference, have a higher smoking pack years, but they were surprisingly less likely to be a current smoker. They also had higher cholesterol, more likely to have diabetes and hypertension. So using linear mixed models for frailty adjusted for statin use, age, and sex, follow-up time, diabetes, hypertension, smoking, and whatnot, this group looked at the impact of reduced frailty over time. So even correcting for all of those other issues, the statins itself did not demonstrate to have a statistically significant effect on frailty, but the interaction statin time. So getting a statin itself does not seem to decrease or slow down the development of frailty. But being on statins for a significant time did seem to actually result in a decrease in frailty. So I found this helpful because, again, I still have patients that when I talk to them about the REPRIEVE study, they're like, well, just give me the data and I'll think about it. I'll look it over and think about it. Again, if statins are really helping people avoid or slow down the progression to frailty, maybe, again, this is another tool that we can use to talk to our patients to adapt this practice. And then I'm going to end my talk on older adults with metformin. So this is actually a very small phase 2 study evaluating the impact of metformin versus placebo on biologic aging using epigenetic clocks and also looking at the impact on mitochondrial DNA. Eligible persons needed to be 50 years and older, have an undetectable viral load, T cells over 500, and basically not have another indication for metformin. So not be pre-diabetic or diabetic. And the primary goal as a phase 2 was to evaluate safety. In this small study, there really weren't any safety concerns, but there also wasn't any clear differences in epigenetic clocks. So it did not look like there was any impact on aging as it relates to epigenetic clocks with metformin. So, it's interesting. I don't know if this group is going to move forward with a larger study. There has been a study on metformin trying to look at aging in general adults for a long time that has not been able to get funded. So I'm not sure if this will move forward specifically for HIV. But I will say that Michael Corley, who has kind of recently joined us at UCSD, did a very similar study in Hawaii. And he did see differences in decreases in the epigenetic clock for one of the epigenetic clocks with metformin. So there may be something to this. The jury really is still out, I think, on the clinical impact of metformin on aging. But if you know patients, if you have some patients that are interested in studies like this, where, like taking medications to address the accelerated aging that tends to come with HIV, the ACTG study is coming up soon, looking at dasatinib and quercetin, which are it's a couple of senolytics. So if you have patients that want and are interested in this study, it's probably going to fill up really quickly. Please reach out to me and let me know, because we actually want to get a big portion. We think it's going to fill up across the country really quickly, but we want our patients to benefit from it. So let me know. Okay. So now we are shifting to a different population. We are going to start talking, we're going to start talking about mothers and daughters, or women. This is a really interesting study to me, because I guess I'd never really thought about this in this way. But women with HIV experience a higher burden of age-related multimorbidity. I think we are aware of that compared to women who are HIV seronegative. And this study wanted to see if reproductive transitions actually contribute to that. So they evaluated longitudinally the WISE cohort to look and see if there was a relationship between parity or prior live births and non-AIDS comorbidity. So diagnosis like hypertension, dyslipidemia, diabetes, cardiovascular disease, non-AIDS cancers, and psychiatric conditions. And they estimated that the mean communicable burden stratified by parity in these 4 age groups. So here on the right side, you see these 4 age groups: less than 40, 40 to 49, 50 to 59, and then 60 and above. The red are women living with HIV, and the blue are women who are HIV seronegative. So, younger women, less than 40 with HIV, do not seem to demonstrate a lot of differences in comorbidity burden until they have 3 or more births, which is interesting. Like I guess I don't know if I would have thought about it in this way. Through the different age groups, you can see differences in comorbidities based on HIV serostatus. I think that's most prominent in the 40 to 49, where, women are having multiple births. But overall, women with HIV, for women with HIV, greater parity is associated with an increased burden of these non-AIDS associated comorbidities. And really, the greatest, I think I'm very interested in getting a better understanding of what the mechanism could be. I hope that this group will actually try to explore that, because I myself am trying to figure out, like what could be causing this. I have a lot of hypotheses, particularly as a mother, I think, which only has 2 kids, not 3 or more. I've got lots of thoughts about, what could be contributing to some of this disparity. But, we will have to stay tuned. I think I might reach out to Jordan Lake and see if
Maile, I mean, it's really well documented in the postpartum period, like what, 6 to 9 months after a birth, there's just increase in comorbidities in general. This is unusual because that seems to persist like decades later, or that you still have that residual effect. But I mean, the postpartum other illness is really quite significant when you look into it. I mean, on a population basis, the rates of events are still really low because they're generally young women, but it's a much higher odds ratio.
Thank you for that, Tim. I have actually, it's not this one. I'm gonna maybe go a little bit out of order then. Sorry. So let's talk about this one next. So this study, basically, this was the surveillance monitoring for ART toxicities. This is another SMART study. This is the SMART study with 2 T's at the end. that enrolled pregnant women with HIV at sites across the US and Puerto Rico between 2013 and 2018. And this study specifically desired to evaluate the relationship between experiences of childhood physical and sexual trauma and HIV outcomes during pregnancy and postpartum. And if you look at the graph, you can see that the demographics between, like pregnant women who had a history of childhood physical and sexual trauma versus those who did not are actually pretty similar in their demographics. Childhood violence was pretty prevalent, however, and it was about a third of all women in this cohort, which is horrifying and terrible. But I think what was interesting is, like in pregnancies of women with versus without childhood exposure to violence, the frequency of unsuppressed viral load is actually pretty similar at conception and delivery, but peripartum or postpartum, 1 year later, there were significantly more women who experienced violence that are unsuppressed. So, I think, Tim, this again just kind of highlights that postpartum time period is very challenging for a lot of women. And I can imagine if you've had women or if you've had children, like pretty close together. So you've got like a 2-year-old, a 4-year-old, and a newborn. That is a particularly difficult time to be managing anything in life. Okay, let me go back to this slide before this. Okay, so
time check just so that you know, 8:46.
Oh shoot. Okay. I'm not gonna get through all my slides. Maybe I will skip some of these. Or actually, I can stop if people have questions.
There's a lot in the chat going
Okay,
on
I'll
too.
stop.
So let me try to back up then.
Okay.
There were, I think it started where Scott actually put down. So this has to do more with the sleep apnea. Are people using EMA devices to monitor falls at home? And I was trying to figure out what EMA was. And so I think Scott said it was ecological momentary assessment. Scott,
So these
Yeah.
are being used to monitor things like movement. And so I'm sure there must be some assessment of falls at home, right? That people outside the HIV field and maybe in the HIV field are using, right?
Yeah, so the EMA in the Geri world is kind of considered standard of care. So like, if you want to get a grant on falls, you have to have something objective, and that's not just self-report like a lot of these studies are doing. So you're right, Scott. I think in the Geri studies, there's always something objective there, if you want to be able to get funded.
But how do we get these for people in the clinic as well then? Like how do we, get objective indicators of propensity for falling,
That's a good question. I think we need to get another grant in order to, thankfully for research, it does enable us to get more resources sometimes. I don't think we can access that for our patients on a regular basis, though. Not currently. That is never going to get paid for by insurance.
Sorry, thank you.
Yeah.
Next comment.
Our patients lie to us. Like I've had patients tell me that when I've asked them if they've fallen, they didn't want to address it and they wanted to address something else. So later visits are like, oh yeah, I forgot to tell you I fell because I wanted to address, like my pain. So I didn't tell you when you asked me and if I fell, I told you no. So I mean, it's getting more objective measures is important. This has happened to me multiple times, by the way. Okay, sorry. Go ahead, Dan.
No worries. Jeff Taylor had mentioned about his insurer doesn't like to pay for pitavastatin, so I think this was getting at the Reprieve data a bit.
Yeah, I have to try a couple others, and then I say they had like a bad side effect, and they have to use pitavastatin, and then usually the insurance will pay for it. But then I have to redo that every single year, right? Because it's not like one time and you're done. It's every year they have to reevaluate it. So I hear you, Jeff.
Nettie, I think in regards to your study with aging, for the study, will folks need to not be frail already? And if you can share the flyer for the study you were talking about.
I'll send you an email, Nettie. It's not yet, I think the flyer is not yet approved, but I can send you the general criteria.
Okay. Edie said, are there studies looking at exercise or activity in older adults with HIV and the effects on aging and frailty?
Well, there is currently a study focused for women. So I have a study that's currently being done at Christie's Place. It's called Women Focused Encounters for Resilience, Independence, Strength, and Eudaimonia. And we have trained several of the peer navigators at Christie's Place to do exercise, acceptance and commitment therapy, and provide empathetic social support. The intervention is 8 weeks long. You meet twice a week. And we still have some space. So if you think that you have someone that would be eligible for it, the caveat being you have to not be taking your medications 100% of the time. 95% counts though. Like, so as long as your patient is not taking their meds 100% of the time, and they have a history of trauma or substance use, they will be able to get into the study.
And I think Jeff and Scott have said that Christine Erlandson has done some studies in this space in regards to exercise and aging and HIV.
Yeah, I mean, I think that there's several people that are doing the work. It turns out you don't need a medication, like, or maybe you can supplement with having a healthier lifestyle and doing the things that we all know we're supposed to be doing, eating well, exercising, not using drugs, etc.
Comment from Larry Lyle. HNRP is incorporating smell tests. Did CROI have any studies with loss of smell and frailty?
I didn't see any smell tests, but I think the smell test is actually supposed to be an early indicator of Alzheimer's disease. So that's kind of a known symptom that can often precede Alzheimer's. So I think that's why they're doing that, not necessarily for frailty. But maybe I'm misunderstanding.
All right. And then regarding, I guess, the study with women and the number of pregnancies, Nidhi said, I would guess they looked at psychosocial factors and socioeconomic status. Psychosocial differences that impact number of children probably also impact health outcomes.
I agree. They did not report it in that particular poster, but I would not be surprised. I mean, they have the data, so they can definitely, that might come with the eventual paper.
Yeah, and I think Sarah also agreed with that as well. Laura said it also used to be standard practice that pregnant patients start and stop antiretroviral therapy during and after pregnancy before the universal recommendation for ART.
Yeah, crazy how far we've come, right?
Yeah. So I think those were the comments. Maybe we can open up here if anyone wants to unmute and ask a question.
I have about a third of my slides that I have not gone through. So we can stop for now. I'm happy to
You
share
can come back next week.
I'm happy to share my slide deck if anybody else wants to look at. Just send me an email. I'll put my email in the chat of things that I think were interesting and important, if you care.
Please send them to me so that I can present them next week, so I don't have to work as hard. All right. Any other thoughts, comments?
I have a general question if no one's bringing up specific questions on the studies. Maile, I know that you had some action items for like local advocacy, and I wonder if you have more to-do lists for some of us maybe outside of the UCSD system, or if you know of or are planning on starting like a work group for this very important and growing group. I think there's a lot here and it's clinically relevant, and I'm just curious what your marching orders would be for us, since you have your mind in this space a lot of the time.
I mean, obviously, you know that I love getting together with you all. So like, if we want to have a working group across the county, I am more than happy to facilitate that. I would love that. I've recently gotten involved with a county standard and strategies committee, and I haven't yet been able to propose anything, but one of the things on my to-do list is to propose, like, what do we want to recommend as a standard for older adult care with HIV. So hopefully I'll be able to move something like that forward. Currently, I'm just learning the process. But yeah, if anybody wants to get together on a working group, go ahead and email me about that too.
Anyone else? All right. Well, thanks, Maile, for an excellent talk. We appreciate it. Next week, I will be doing the talk on on metabolic issues and comorbidities. So we look forward to seeing you next week, and everyone have a great weekend. Take care. Thanks, Maile.